This is a very interesting HRCT of the chest, high resolution CT scan of the chest. You can simply pause the video and you can try to figure out what is the problem. Now, when we see these lung parenchyma, when we see the uppermost apices of the lungs, what we can see very clear that this is the lung, that very crystal clear. It is very much apparent that there is no such lesion which is present on this side. This central thing is trachea because this is in the center. This is exactly in front of the vertebra. It is in the midline and it has air inside. That is the reason why it is very dark black, because air appears dark black, jet black on the CT scan. Now, what we are seeing in this, that this there is a one cavity. There is one cavity because there is air inside and it has a very thick capsular covering. You can see this is so much thick. This is all thick margin of this cavity. Now, we must know that presentation of cavity, it means that there is extensive damage of that lung parenchyma. That is the reason why there is formation of this cavity. These type of cavity, it is almost always, you have to think of tuberculosis, because in TB this type of formation of cavities is extremely common. And what we need to know is कि such cavitary lesions are the focus, or they give so much of opportunistic chance for the immunity. So the risk of opportunistic infection markedly increase if there is formation of cavity, because the immunity here, all the CD4 cells, CD8 cells, or the local immunity cannot very effectively combat the bacteria which are present there, or viruses which are present there, or the fungus which is there. So such type of cavities are very commonly affected with secondary opportunistic infections like aspergillosis, like fungal infections, like secondary bacterial infection with any gram positive, gram negative bacteria. So such cavities markedly increase the risk of secondarily bacterial infection, secondary opportunistic infection. Aspergillosis is very common in such cavities, and we can very commonly see the fungal ball, so that it will appear like this. So you have a cavity, and inside that you will have a ball like structure. So presence of this type of ball with a cavity, it is almost always aspergillosis, what we call it as fungal ball. We must know this because such patients won't improve with antibiotics. Such patients will definitely need voriconazole. With voriconazole, the patients markedly improve with voriconazole if it is aspergillosis. So this CT scan is very nicely showing multiple fibrocavitary lesions. Now this is cavity and this is fibrous lesion. So this is fibrocavitary lesion, and there are more than three. There is one more thing. If it is tuberculosis, or if it is a tubercular cavity, then such patients will definitely have a AFB stain which will be positive. So such patients in their sputum will always have 2 plus or 3 plus or loads and loads of tubercular bacilli. If it is not because of the TB, then, and if the patient has this type of cavities, so which is very commonly seen with staphylococcus can also cause such cavitary lesions. So if that is staphylococcus cavity, then that will, and if it is not TB, it will not show any TB bacilli. But if it is TB bacilli, then it will almost like 90 to 100%, it will definitely show positive AFB stain. So AFB stain will be positive, gene expert will be positive in the sputum of such patients. So we should think that this may be staphylococcus if the sputum is negative for AFB stain or Gill-Nansen stain, that is for tuberculosis. Now, what other things we can see in this particular CT scan is there is one dense white patch which we can see on this left lung field. Now, such type of patch can be either two things. It can be pneumonia, or it can be a fibrotic patch because of the old infection. So presence of this cavity with such patch highly suggests that this is active lower respiratory tract infection, or it is an active pneumonia patch. One more thing, if it is fibrotic or if it is fibrosis, then there should be contraction of this space, because there is, if this is fibrosis, there should be loss of lung tissue. So there should be more of a contraction. So this and this distance is almost same as this and this, or this and this, or this and this. So this border and this border, they almost have equidistance from each other. So if there would have been a fibrosis, this space or this distance would have been slightly lesser, because there would have been a pull of the lung parenchyma. This is one thing, so that goes against the favor of fibrosis. The second thing, if this would have been fibrosis, the mediastinum would have shifted to the left side, because fibrosis simply pulls the mediastinal structures toward the same, or it pulls the trachea toward the same. But in this, what we can see, the trachea is sitting perfectly in the midline. So there is tracheal pull is not there. In fact, the trachea is more toward the right side, which is very commonly seen. Trachea is slightly deviated to the right side. Here also we can see the trachea is getting divided into right main bronchus and left main bronchus, and it is in the middle of the vertebra. So this lesion is not pulling the lung toward this side. So this is very highly unlikely to be a fibrosis, and that is the reason why this is definitely a pneumonia patch. So in short, this CT scan is showing the active fibrocavitary lesion and a patch which highly suggests TB. In such patients, sputum should be definitely sent for AFB, that is acid fast bacilli, or ZN stain, that is for tubercular bacilli. It should be definitely sent for culture and sensitivity. And if the patient is immunocompromised, alcoholic, if the patient has cancer, then if there is a risk of TB, anti-TB medicines resistance, then definitely we should also send for TB culture and sensitivity, because the report may take more days to come, and appropriate anti-tubercular medicines can be given in the future. We can also, if you are suspecting, we can definitely say, if you are suspecting aspergilloma or aspergillosis, we should definitely send serum galactomannan, which favors the diagnosis of the aspergillosis. But serum galactomannan is very commonly found false positive if the patient is on cephalosporins or amoxicillin or piperacillin tazobactam or meropenem or any other antibiotics. So such patients should be always sent with gram stain, AFB stain, culture, routine culture and sensitivity for bacterial culture and sensitivity, and TB culture and sensitivity. If the patient is not responding to antibiotic and any very specific people, we can send it for fungal culture and sensitivity. So this is very interesting CT scan showing multiple fibrocavitary lesions. There is no any fungal ball in it, and it is showing an active pneumonia patch, so which should definitely have good AFB bacterial presence in the sputum. This patient had 3 plus uh, tubercular bacilli in his sputum. That's all for today, and thank you.